Hello, this is Dean, and this is a tutorial on how to interpret ECGs, and then I'll give you a little tip on what the treatment is for those different dysrhythmias. I'm going to focus primarily on strips, not really the 12-lead ECG printout. It's a little bit easier as a starting point, and we'll get to those other more complicated things a little bit later on. So this is what you're going to see when you have a printout from the telemetry or something similar. You're going to see a little funny waveform, and so we'll talk about that, exactly how we're going to interpret that. The previous video, if you watched that, broke down the paper and how it was set up and gave a little bit of intro on the normal physiology. So we're just going to jump right into interpretation. What I'd like to do, though, is encourage everyone to use a systematic approach, or I like to call it a head-to-toe assessment, like you did with other things. Like, for example, when you learned how to assess a person, you started with their head and went through that and down, and you finished at their feet. And it just kept you on track, so you had this outline because they were a body there, and so you use that as your outline. You didn't forget anything as you went along. So I like to use this systematic approach. And the first thing, or in the head spot, is the rate. So we'll first need to determine what is the rate of this rhythm, and then what is actually the rhythm of it, meaning is it regular or irregular. Then we'll look at the P wave in its relationship with the QRS complex. Is there a P wave? Is there one for every QRS, etc.? And what is the PR interval? That will help us identify some specific dysrhythmias. What is the QRS like? Is it normal? Is it narrow? What is the ST segment? Is it back to its baseline, or is it elevated? And what does the T wave look like? Then maybe we'll look at those different intervals. And what I want to do is identify those very key characteristics that will help you identify the major dysrhythmias, so that you're going to be needing to know and intervene if you're working as a nurse. So first, make sure that you have a full 6-second strip. Now you can do that by counting the boxes, or sometimes they'll have little hash marks, like on this one right here. If you see over to the left, you have a little hash mark there, a hash mark in the middle, and then a hash mark at the end. These ones are indicating a 3-second segment here. So as we see here, 3 seconds here times by 2, we'll have a 6-second strip. And that will allow us to easily get enough information to interpret that rhythm that's on there, identify it. So make sure you have that, at least 6 seconds. And you can do it without, but it's so much easier if you have a minimum of a 6 seconds. So let's go back to that first part. Like I mentioned before, is measuring the rate. I'm going to tell you a couple different ways here. They each have their own advantage and disadvantage, so if you know several of them, you can use them in the right circumstance when you don't have to worry about the disadvantages, and then it just gives you an opportunity to pick and choose for yourself what you like better. My personal favorite is you grab that 6-second strip and you count the QRS complexes and times by 10, because remember, back in grade school, it was really hard to remember your multiplication tables, but when you got to the 10 times tables, it was so easy because you just added a 0. So awesome. It's totally easy. Method number 2 is that you count the large boxes on the paper between 2 R waves, and then you divide by 300. That seems a little bit more complicated than it needs to be, but when we get to looking at the paper and the strip, I'll show you what I mean by that. And then 3 is so much closer to, or it's very close to 2, except for you're doing the same thing, but you're counting the small boxes between 2 R waves, and you're dividing by 1500. You think, wait, why would I even want to do that when I can just do method number 2? Well, in order for this to work, that R wave, the point has to be right smack on the line. And if you have a short strip and your R wave is not exactly on that dark line that indicates the border of the large box, that doesn't work right. So you may have to go to this method number 3. Now, if you are trying to figure out the atrial rhythm and not necessarily just the ventricular rhythm, you do the same exact thing, only you look at the P waves instead of the QRS complexes. So here it is laid out on a strip, and you can see that my favorite way is quite easy to figure out there. You just take your 6-second strip and you count them up times by 10 and you get D. Now you can go through the other ones too and see how some of them are not. This first one, see, is right on that line right here, so it made it pretty easy to be able to do method 2. Now what happens if it's not exactly on that line? You don't have a big long strip to look at. You can do it like over this one. Okay, it's right on that line there, and now we just count those and divide by 1500. So that is a way. Now another way that I kind of like, and this is very similar to how if you ever looked at your pulse oximeter and the rate goes up and down if the person has a irregular heart rate, and you're like, why is it sometimes 80 and sometimes down to 70 and just bounces back and forth? Because it's reading between the R waves. And this is a way you can do that if you just have 2 R waves. And this is great if the rate is regular. But if it's irregular, this is not going to work out very well. You'll have an inaccurate reading. But if it's regular, you can just start on find an R wave that's right smack on the line. And for every large box, you count down on this specific pattern. Now the catch is you have to memorize this pattern or it doesn't work. So you start here and you go to the next one, and that would be 300. So if you had an R wave that was on that one, your rate would be 300. Then it drops in half to 150. Then it drops 50 to 100, 75, and the next one is 60, and then the next one is 50. Now this works pretty well. I'm not going to go down further. Again, this is more of a ballpark figure, so if you're going to take a quick little look and you don't want to have to add up more than just a couple things, you can use this. So what rate would this be? Somewhere in between 60 and 75. So I'm going to say it's right around 65 because it's not quite in the middle. So it would be somewhere around 65 beats a minute would be the interpretation of the rate on that strip. Let's jump right in now to identifying the rhythms, and we'll go through that same pattern like I mentioned before, and I'm going to bold on the slide the key element that you should really focus on in order to identify that particular rhythm. Now we're going to start with the easy one, normal sinus rhythm. I think it's important to start with that so you know what normal looks like. So the rate. For it to be a normal sinus rhythm, the rate needs to be in the normal parameters, which is 60 to 100. The ventricular and atrial rhythm are regular and they have to be the same. So the ventricular rate and the atrial rate are the same. QRSs are normally skinny and they look normal. The P waves are normal looking, consistent in shape, and there's always one in front of every QRS. And the PR interval is between 0.12 and 0.2 seconds. So the treatment for this, if you couldn't figure it out, is nothing. We don't treat normal sinus rhythm. In fact, that's what we all want to be having as we walk around and live in our lives. We want our patients to look like this. So again, we have a P wave in front of every QRS. The rate is regular and normal. So again, use this as a reference as what is an example of normal. Now, sinus bradycardia. Now, you might remember from your experiences learning medical terminology that cardia is heart and brady is slow, so a slow heart. Now, there's different types of bradycardia. This is called a sinus bradycardia, and whenever you hear the word sinus in front of the name of a rhythm, you know that the impulse originated in the SA node. It's very important. It has to be that way for it to be called a sinus rhythm. So in this case, we know that this impulse began in the SA node. The rate is less than normal, which is less than 60. The rhythm is regular. the QRS shape is normal. The P wave is in front of each QRS, meaning they're matched together. So you always have a P wave in front of each QRS. And the PR interval, the PRI, is consistent. It's always the same. It's not shorter or longer, and it's in that normal parameter of 0.12 to 0.2. All right, so now, why might someone have this? Now, they could just be like this normally. You know, you get these marathon runners, people who have healthy hearts, their cardiovascular health is great. They're just cruising around their life, less than 60. They have no symptoms. They're happy. It's fine. We don't do anything to treat them because they're fine. But what if they're not fine and they feel like they don't have the proper amount of perfusion that's getting to their brain, and so they're dizzy, they're weak, those types of things, or maybe it was temporary, did they have a vagal response? So anything that was going to cause them to bear down, hold their breath, something like that, then maybe they are at this point because that's why they did it. So we treat the symptoms if we can figure out why. The number one and preferred treatment is to give atropine, and there's a range of that. To give IV is 0.5 to 1 milligram, and that's the treatment of choice. Others follow, you know, there's other things you can do, but that's the number one treatment. This is what it looks like on the ECG. So if you remember back to those things that I mentioned before, you can see that there's the rate. If we count it up here, this is a 6-second strip. These little hash marks here are seconds. So 1, 2, 3, 4, 5, 6. Roughly we have a little piece over here. So it's about a 6-second strip. And we count those 1, 2, 3, 4, 5, my great method. Then it's 50. We know that's less than 60. It's the normal parameter, at the bottom of the parameter. So now we have a rate of 50. The distance between the P is within that 0.2. It's not any longer than that on each of them. It looks the same. So we get those key elements. We know that because we have a P wave, it started in the sinus node, or the sinoatrial node, and so we have that right there. It's those key elements are present. We know that's a sinus bradycardia. Now, sinus tachycardia, remember, the impulse started up there in the SA node. The rate is greater than 100. Again, so it's higher than the normal parameter of 60 to 100. The rhythm is regular, QRS is normal, the P wave is present, but you know, because we get so many of them back to back, it could be the P wave is underneath the T wave, and it gets kind of hard to figure it out. And so sometimes we need to slow the rate down by doing a vagal response or giving a medication, and then we can see that P wave to really get a good look at it to make sure that it is originating in that SA node. So you can see the other items here on the slide. What we're going to do to treat that is we're going to try to treat the symptoms and slow this rate down. If we can figure out why they're this way, that will help. Otherwise, we can use some calcium channel blockers, beta blockers. Those are some good classifications of medications that help slow the rate of the heart down. So this is what one looks like. I chose one that you could easily identify the P and the T's as separate. So here you go. It fits that category. Again, if this was a 6-second strip, what would be the rate? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 120. Above that minimum range, we're above the regular rate, which is 100, so we're 120, it's well over that. Looks same, looks normal, but it's just fast. So now, supraventricular tachycardia is similar, but it is not originating in the SA node, that impulse. So it's up there in the atria someplace above the AV node, but it's not the proper conduction. So we don't call it a sinus tach. It's supraventricular tachycardia. So it's happening above the AV node. That impulse is starting up there somewhere, but we don't know where it is. It's very, very similar to sinus tach, except for the rate is usually higher. The P wave, again, is going to be weird looking because it's not an actual SA node beginning point, but it could be there because the impulse could start very near it. The next thing that you need to look at to identify this particular. So the main thing is it's usually a higher rate, and you need to look at that P wave to see exactly where it is, and you're not going to see that normal looking P wave. So these are a little bit difficult to distinguish, but if you just keep an eye on that P wave, and the rate is generally higher. Here you can see it looks very similar, and without slowing it down, this could be an example of a sinus tach 2, where the two waves, the T wave and the P wave, are so close it's kind of bunched up. So these are very hard to determine which one is which. But again, if you count it up, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 180, much higher, even though you could have a sinus tach at a higher rate, but these are generally the really fast ones. Now, a sinus dysrhythmia, these are kind of odd, and so we'll take these each bit by bit here. The rate is usually a little in that normal range of 60 to 100, but it could be slower depending on what's going on there. The rhythm is regularly irregular, meaning that you're going to have a beat and it's going to follow along, and then all of a sudden there's going to be a pause, and then it's going to follow along again, and that space between the pauses and the beats are going to be the same. The QRS complex looks normal. The P wave is normal, but the P wave or the P to P interval varies because there's going to be this pause. Okay, so again, treatment on this is what is going on with them. Maybe this is nothing, but it might be a reason because they have a toxicity of medication. Digitalis is one of those culprits usually that's going to cause that. If they are really bradycardic and symptomatic, then we would treat with atropine just like we did for sinus bradycardia. Let me show you on this strip what I mean by, so they're going to be irregular here. They're not going to be the same. So whatever reason their SA node is not firing at a consistent rate. So it's just going to be a little bit funny pause. Now, when we get to another rhythm that is irregular, we're going to look at the P wave. So if you have an irregular rhythm here, but you have a normal looking complex every time, you have a P wave, it's got a normal distance here, the QRS complex looks normal, and a T wave. All of them look great. They look the same, but you still have this irregular rhythm, then that is called a sinus arrhythmia. That is the key characteristics. Now, right here, what I want to do is show you how an easy way to figure out if these are regular. You can get yourself a caliper, and it has little points on it, and you can put 1 point here, 1 point there, and then you can move that distance to the next one. You see that it's smaller here than over here. Or else you can just get a piece of paper. Now, if you get what right now and grab a piece and hook it up to your screen right now and just mark the edge of the paper where each of these are, and then you can slide your paper over. That's kind of what I call a poor man's caliper, and it will work every time because you have those little hash marks on the edge of your paper and you can slide it over. So if you're at work, you can just grab a scratch piece of paper, make a hash mark on each of those lines, slide it over, and you can tell really easily if it's regular or not. Now let's get into the heart blocks. These is where all the time students get so confused. Even nurses who are working in the field for years and years, they're like, I can't remember how to tell the difference between the AV blocks. So I'm going to go through them piece by piece and tell you exactly how to identify the different AV blocks. And you'll be able to remember them so slick, and you'll be the pro in no time. So the first degree AV block, these look almost just like a normal sinus rhythm. However, the key change here is that the PR interval is greater than 0.2 of a second, and that measurement is the same. So key here is the PR interval is bigger than one of those big boxes on the paper, and it's the same. It's always the same. It doesn't get lengthened, it doesn't get shorter, okay? So that is the key thing. We don't usually treat this unless something else is going on. Let's take a look at what it looks like. Okay, so right here, let's find one, this one right here. So this, the beginning of the P wave, is right on that dark line. Okay, do you see that? Now we're going to count over, and if it's bigger than one of these boxes, we know that's greater than 0.2 of a second. That's what these are, right? Remember back then? So this right here is, it's basically a big box and a half. And if we look at it, if you wanted to get your poor man's caliper out right now, put your piece of paper up here and start a hash mark right here and the other hash mark right there. So you have one here, one there. Let's slide it over to here. Oh yeah, it's the same. Oh, a little bit different. Oh, but it's so close you can hardly even tell. And then here and there. So that's consistent. So greater than 0.2 for a PR interval, and it's consistent. That is the definition of a first-degree heart block. Second-degree heart block, type 1. There are two different types of second-degree heart blocks. This one's also called a Mobitz type 1 or a Winky block. These names get kind of confusing, so I don't know a great way to tell you how to remember that. I'll make another little video of some tips on how to remember the rates, or excuse me, the different types of blocks, but not in this one. This is going to be long enough as it is. So remember that there's second degree type 1, so AB block type 1, Mobitz type 1, or Winky block. Okay, so atrial impulses, so we're going to have a P wave that there will be more of them than the QRS complex. So again, as we go through that systematic approach, our rates are generally normal. But the key thing to identify a second degree heart block type 1 is there are more P's than QRS's. And here's the really important thing. The PR interval is normal on one beat. And the next beat, it gets a little bit longer. And the next beat after that is a little bit longer still. So you're going to get this progressive lengthening of the PR interval. And then all of a sudden, a QRS is missing. Now, if you're missing a QRS, you will not have a T wave. Okay, so why would this be happening? This could be a process of myocardial ischemia. Back to that ditch toxicity again, or electrolyte imbalance. Many things can cause this. If you can track down the history, figure out what the cause is, we would treat that cause. What we were also worried about is when we're losing that QRS complex, we lost the whole beat. So blood pressure is going to drop a little bit. Their perfusion is going to be, not as good. So if these are overall a bradycardic rhythm, we're back to treating atropine and maybe even pacing if we have to. What does it look like on a rhythm strip? So here you go. Here's one right there. This first beat on the strip looks normal. The P wave is looking normal. The distance is normal. QRS complex is normal, and the T wave looks normal. Okay, everything here on this beat right here, we think everything is fine. We move to the next one, and whoa, what happens here? We are almost, we are at 0.2 all of a sudden right here. That distance is suddenly longer. Lengthening PR interval. Let's go to the next one. Ooh, even longer still. And then, boo, we're missing a whole QRS complex right there. And then we're back to normal again. Longer, and guess what? You can't see it right here, but you can guess what happened right there where I'm wiggling the cursor. What happened right there? Dropped QRS. Now, a second degree AB blocker type 2, or also called a Mobitz 2, these are very similar. People get them confused because Mobitz 1, Mobitz 2, second degree, which one's which? They are the same except for the PR interval is normal always. It doesn't get longer. It's the same. So it's very much the same as the other one. As you see down here, the stuff on the slide is the same. Let's just look at it. So here we go. Sort of, you can see it back here. A normal looking QRS complex with a P and a T. Everything's fine. All of a sudden it's dropped, dropped, normal, 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 dropped. So every once in a while, you are just going to lose that QRS complex. There's no lengthening of the PR interval. Okay, so that's the key characteristic. You're dropping QRS complex without lengthening the PR interval. Similar things are going to happen here. So what is the rate here? We just skipped that step, went right on to the next thing, because I'm trying to go fast. But 1, 2, 3, 4, 5, 6, 60. We are at the bottom range of normal here. So if this person is used to having a rate that's more like this, then they're going to feel it. You're going to feel yucky. Now, a third degree AV block, the atrial rate is faster than the ventricular rate. So if we look at and count the rates of each of those, so you count the P's, count the R's, the rate of the atria are more than the QRS's. The ventricular rate is usually slow, like less than 45 even. The P to P interval and the R to R interval are regular. They are the same, meaning R to R is the same throughout the entire strip, and the P to P is the same. But there's no relationship between the two of these. So what's happening is the atria, they're sending an impulse, boom, 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 and the ventricles are not getting the message, and they're doing whatever they're doing at their own intrinsic pace, which is like slow. So it's like atria beat, 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 ventricles are beat, beat, beat. You know, it's going to be the same. So let's take a look at this on the strip. But again, what could be the cause of this? Several different things. This is kind of bad though, because your ventricular rate is slow. They are going to be symptomatic, and they're not going to feel good. So if we see this and they have hypotension, they look like they're not getting perfused, we need to intervene. Again, atropine might work. No lidocaine, because that's a antiarrhythmic that has a slowing type component to it. We just don't want to go any slower than we're already going. We also could try transcutaneous pacing to speed that thing up. All right, so I put a couple of these examples up here. So you see now, get your poor man caliper out, and let's do, this is a 6-second strip, so we're going to count them 1, 2, 3, 4. So it's a 40, this top one here, the rate is 40. Now let's look at the P waves here and see what the atrial rate. So there's one there. So get your poor man caliper up here, your little piece of paper, make a mark right there and another mark right there, and slide it over to this one. Now it's the same distance, same distance, same distance. So our atrial rate is the same, and if we count them 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 110 is our atrial rate, and 40 is our ventricle rate. So they're offset. They don't match up. Now it's kind of confusing because look, oh, here's a semi-looking normal PQRS T complex. All this together looks normal, right? So does that one. So does that one. It just happened to be hitting on it. But you can tell there's no real relationship between the two. Down the one in the bottom here, same sort of thing. If you measure them out, they are the same. There's one here, a P wave, but you can't see it because it's hidden behind that QRS complex. So you can see it's not always just a total cut and dry, super easy way to do it. But this is the characteristic, the key elements of a third degree heart block is that your P waves are greater than your QRS's, and they have no relationship one to another. And it's a slow rate. Sinus arrest. Now this is something that's similar to what we call sinus exit block, and so I want to differentiate between those two. So sinus arrest, you have this normal looking heart rate, normal looking tracing, and all of a sudden there's this pause. Kind of like back to our sinus dysrhythmia, but this is different because the pause is not easily not consistent, and the P to P intervals, you got to look at the P to P's, and you can tell the difference between this and the others. The P to P intervals are different. Now, why is this happening? the sinoatrial node just stops firing for for a brief period of time. Again, why is this happening? Don't know. Oh, dig toxicity is a probability. Could be having a heart attack, something like that. Again, if the rate is so slow that they're having symptoms, we may need to treat with a pacemaker or transcutaneous pacing until that can happen. Here's what it looks like on a strip. So you have this normal looking rate here, and then all of a sudden this pause, kind of funny looking thing, and then it's back to normal. The key thing here is if you were measuring the P to P, and if you were to guess where this dropped beat would be, you could say, oh, there's probably a P there, and then that distance would be the same to that one. Okay, kind of confusing, I know, but if you measured them out, get your poor man caliper up here, and go here to here, and then you slide it over, we're here, and the next one would be here, and then the gap there is different. So this, as we indicate down here on this little graph, the P to P interval is not consistent, which is different on the next one here, the sinus exit block. This is the same thing except for the P to P intervals are consistent. Okay, so that dropped beat, it's going to pick it up at the same rate. It's going to like remember, oh, I missed that one. I'm going to start it up again where I left off, and it's going to be exactly right on. So again, if we did P to P, start over here, P to P to P, and then exactly there's a P right there. So that P to P interval is the same. That is how you tell the difference between a sinus back here, sinus arrest, and a sinus exit block. And that is because on a sinus arrest, that PP interval is not consistent, but sinus exit block, it is. Okay, that is the key characteristic to differentiate the two of those. Now, asystole. Awesome, finally something that anyone can learn how to do, right? You got this one already. You know what this is because you've seen at least one medical show on TV or a movie. This is where we have no electrical activity or a flat line. Now, if you see that, you want to look at your patient. Do they look like they have a heart rate? If your patient is looking at you in the eye and you see asystole on the monitor, then you better check your leads because something's disconnected, something's not right. If they do not look like they are alive, like they have no pulse, no blood pressure, then you need to start CPR because there's no heartbeat going on. So one thing I want to add here, before in advanced cardiac life support, they said that American Heart said that we should give atropine, and that is no longer the case. That's a change in the last time. So we don't give that. The treatment of choice is CPR. Perhaps you could do pacing, but we're going to give all the medications that we would do in a cardiac arrest situation and go from there. Again, this shows two different leads. You always want to check two different leads to make sure that it's happening in multiple leads, that your connections are all right. And so it's just that kind of funky flat line. No waves you can see. Everyone on your test, and if you ever see this in real life, you should be able to quickly identify asystole. Even the common Joe knows what that B flat line is all about. That means you're dead, if it's real. Atrial fibrillation. Okay, so we're going to look at this again, go through that same process of what is the rate. And you're going to see here that your rate is usually, well, it could be either one. It could be fast or slow. But we're going to have a really hard time figuring out where that P wave is. Now, I put up here the atrial rate of 300 to 600. Now, if you have a fancy machine hooked up to your patient and it's going to be able to tell you what the atrial rate is, it's going to get kind of confused and it's going to register an atrial beat when it's not really there, and so it's going to be super, super high. And so that's not really an accurate thing to say that that's what the atrial rate is, because you really can't see a P wave if you're a human eyeball looking at it. The rhythm is always irregular, so that if you're looking at atrial fibrillation, you're wondering if that's the case, the key things are no discernible P wave and the rate is irregular. All right, so now when did this occur? When did it start? If we know the start was less than 2 days ago, we may choose to cardiovert that person. If we don't know, then we will often choose to give them an anticoagulant for a while and then cardiovert them after that. Because what happens if that atria are not contracting well, they're just quivering, then a blood clot can form up there, and we don't want them to get a PE or a stroke. So we choose to anticoagulate first and then try to put them back into a normal rhythm. So let's look at this strip here, and you can see we're going to go look at the rate. 1, 2, 3, 4, 5, 6, 7, 8. It's normal rate within that 60 to 100 range. But now we look at the rhythm. So our poor man caliper, again, drag that paper up here, make a little mark, make a little mark, and slide it over. Close, but not quite the same. And then, whoa, way longer here. Oh, then we're back to the one that we have it over here, and then long again. So it's just not consistent here. So we have this irregular rate. And let's go to the P wave. Can I see one? Well, is that a P wave or a T? I don't know. Jeez. You can't tell. Jeez, you know, especially what's happening right here. I mean, for real. That is nothing I can tell what's happening there. So we have with that, I don't know, maybe that could be a T wave, or I don't know, maybe it's sort of a P. But consistently, you just don't see it happening. So there's no real discernible P wave consistently throughout this. And and then couple that with the irregular rate, we have AFib right there. Atrial flutter. Now you think, ooh, how's that different than AFib? I'll show you. The atrial rate is easier to tell because you're actually going to see P waves, and it's going to be greater than the ventricular rate, and you're going to have more P's than QRS complexes. And now down here, the P wave characteristics are, if you have someone describe it, say like on a test, if you were a student right now thinking, how am I going to know what this is on a test if they don't show me a strip, they just describe it in words, I can promise you they're going to use words like sawtooth or a picket fence type pattern of a P wave. Okay. Now, what's going to happen here? What their condition is going to be like, if they're slow, their rate is slow, we don't have a really great perfusion pattern going on here, we will need to cardiovert them and get them back in line so that P wave is in front of every QRS complex. If they are stable, we may give adenosine if it's fast. Just depends on what's going on with the patient. But let me just show you here on this strip what I'm talking about when I say identifiable P wave. It's hard to tell which is a T and which is a P, but in this case, you see this picket fence, sawtooth type pattern. Our rate is 1, 2, 3, 4, 5, 6, 7 normal rate. Our R to R, if you put your little caliper up here and you measure it out, they're pretty much consistent. And you have usually, in this case, you're going to have the same number of P waves each time in between the beats. So you're going to have we'll just say that that's a, I don't know if that's a T wave or not. 1, 2, 3, 4. That looks the same in every one. See how that hump looks the same? So we're going to call that another P wave, and that could be a T wave right there. We don't know. But let's just count 4 bumps here. 4 bumps, 4 bumps, 4 bumps. So it's consistent. Atrial flutter, more P waves than QRS complexes, a regular rate, you got atrial flutter. Now a PVC, a premature ventricular complex, this is kind of one of those odd things that everyone out there, you, me, we all have them from time to time. And so if we have them from time to time, it doesn't really matter. You might have felt something one time, you're saying like, ooh, my heart skipped a beat. This is when something besides the normal conduction pattern occurs and the impulse begins someplace else. Now, if we don't see a lot of them, no big deal. And usually what happens is it's in a similar spot. Like you'll get a part of your ventricle that gets kind of excitable and says, hey, I want to be the new pacemaker of the heart, and he just sends off an impulse. And it's not in order, it's not in the proper conduction system, so what ends up happening, you have this funky looking beat. I'll show you what it looks like on a pattern here in a minute. So the duration of the QRS complex, remember if we were measuring how wide it is, it's longer than 0.12. And the shape looks weird. It doesn't look like a normal QRS complex. Now you might see different shapes, and if that's the case, it's called a multifocal, and I'll show you some more of those in just a minute. If you see a lot of these and the patient's getting symptomatic, because when that other beat happens, that PVC occurs, we're not getting a good ejection of blood from the heart because it's the impulses and the wave of depolarization is going all over the place. It's not a proper contraction to eject blood out normally. So they might have a decrease in blood pressure. We don't usually use lidocaine in these cases as an antiarrhythmic, but you could do it if the prescriber is so inclined. So here we go, a normal looking ECG strip cruising along, da da da, all of a sudden, bleh, what the heck is that? And then back to normal. So you see this thing here, it's wider than that 0.2, right here, one box, boom, right there. It's way wider. It's hard to even tell what's going on. Was there a T wave? I don't know. So now you have this bizarro thing, but it's just one. That's a great example of what a PVC looks like. No biggie if it's only one. Now we get into trouble if we have multiples or they're different shapes. So keep in mind what's causing this is an excitable area of the ventricle that's sending out an impulse. Now this top strip up here, these are actually two different leads of the same rhythm. But so you're having this weird one here, a normal one here, weird, normal, weird, normal, weird. So when it's a consistent pattern like that, every other beat is a PVC. That's called bigeminy. If it's third, it's trigeminy, and if you have four of them, then it's quadgeminy. Now this bottom one down here shows you multifocal. So let's go along. We have a normal looking beat pattern, normal beat pattern, and then all of a sudden, whoa, this weird thing happens right here. And we look at the shape of it. Okay. A bizarre QRS pattern, it's wider than normal. Then we go along, it's normal, 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 then a different one. This is another bizarre QRS complex, but it's different than that one. And as we go on, then we have another one that's different still. You think, well, what's the big deal, really? If you have multiple areas of your ventricle that are trying to be excitable, trying to send out its own little impulse, be the pacer of the heart, it gets to be problematic because the more areas of excitability you have, the more chances you're going to have of a total disruption in the normal conduction pattern. And these crazy areas of the heart may just take it over, and you're going to end up with another pattern that I'll show you later on. Ventricular tachycardia. Okay, so tachycardia, you know, is going to be fast heart. So it's over 100 beats a minute. Notice I didn't say sinus here. So that means the impulse is not coming from the SA node. It's coming from the ventricles themselves. This could be that we have PVCs that are all stacked one after another. A short run of VTAC is if you get 3 or more PVCs back to back. So you might see that normal heart rate cruising along fine, and then 3 or 4 or 5 PVCs, and then back to normal again. You had a short run of VTAC. The rate here is during this time is 100 to 200 usually, greater than 100 for sure. Your QRS duration is longer than 0.12, so they're going to be wider QRS complexes. They look funny. They're not a normal looking QRS complex. The P wave, you just can't see it because if it's happening, then the QRS complexes are going to hide it because that's where the bigger chunk of the muscles are, and you're just going to see all that electrical activity happening in the ventricles. If there happen to be something happening in the atria, the ventricles don't care. They're not listening. They're doing their own thing. So again, what's going on with this person? This is not going to be a heart rate pattern that can sustain perfusion. The blood pressure is going to go down, that's not got a good cardiac output happening. And so we're going to look at the person and decide how are we going to treat them. If they are not conscious, they look terrible, we can defibrillate this person. Your AEDs, your external automated external defibrillators, they are going to sense this rhythm, and they're going to say it's okay to shock that. If they're awake and looking at you and go, oh, I feel terrible, I don't feel right, then we may choose to cardiovert them or use medications, either with electrical cardioversion or medication cardioversion. So we'll try to snap them back. So here's a couple different strips showing this. If you were trying to make a guess of what the rate is, we go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 20, 21, 22, and 23. 230 is their heart rate. Let's do this one. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 18, 880. So listen slightly slower, but still wide pattern, looks funny. That's the key characteristics of ventricular tachycardia. Wide pattern of QRS, greater than 100 rate. Doesn't look normal. They look bad usually. They can't go like this for very long. Ventricular fibrillation. So this is a rapid and disorganized rhythm. There is no real contraction happening. It's just quivering of the ventricles. Again, if you can think back to the PVC we were talking about before, where you have lots of areas of excitability, if you have 50 spots in that ventricle that all wants to do the pacemaker and it's just sending out impulses all over the place, you're going to end up with ventricular fibrillation sooner or later. Now, if your machine that's fancy and hooked up to the patient can determine a rate, it's going to say it's more than 300, but really there's no real discernible R wave to say, okay, this is the rate. Most of the time, you're not going to be able to register a rate, and this does not produce a pulse. So if you see this on the monitor, your patient is not going to have a pulse if it's real. And so if that's the case, what's the treatment? They have no pulse? Yeah, you guessed it. If you're BLS aware, you're going to do CPR, right? And we're going to defib these people. So a couple different patterns here. This is called a coarse pattern, where it's really wavy. So again, we can't really tell. It looks sort of like VTAC in some places. I think it's fine here, and anyway, it's messed up. And it could be a smaller waveform down here, a fine VFib. Again, no pulse. They're dead. We got to do something, or they're going to stay that way. So that's really the end of the major rhythms that I think you're going to need to know. But I want to remind you, what's your overall impression of this rhythm strip? When you look at it, does it look normal or not? Then go through that systematic pattern. What's the rate? What's the rhythm? Is there a P wave? Does the P wave look normal? Is there a P wave in front of every QRS? If so, what's the distance? Does it change? That PR interval is very important. What does the QRS look like? Is it narrow, less than 0.12? Is the ST segment elevated? And is there a T wave? Seriously, it's not that hard. Go through that systematic approach and you'll be able to identify these key rhythms without any problem. Now, if this was helpful for you or you have other questions, feel free to comment, or even better, subscribe. Do both. I'd love to help you out. And thanks for watching this. I know it was long, but we covered so much, and now you're so much smarter than you were before, right? I knew it. Okay, thanks.